Sometimes we just have to point to other clinical practice guidelines and to other position statements and things like that, where the evidence is not available, but we know we need to make a statement about this because we know that something that the perioperative nurse and the perioperative team need guidance on. It's always frustrating when, as an OR nurse or as a surg tech, when you know that you have a question and you go to your place where you're supposed to get your guidance and it says, sorry, we can't give you a recommendation.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
On today's episode of First Case, we are wrapping up Season 13 with Zach Swartz, a perioperative practice specialist at AORN. And this season, Chris, we have covered a variety of topics, and today's episode really is absolutely no different. We're actually going to be covering 2 topics in one today.
And he's such a great guest because, number one, he's going to inspire you to do the right thing for tourniquet safety, but also he is going to inspire you to take a deep breath, be in control of your breathing, not just your mindfulness in the operating room, but outside of it. I don't know. He put me in a spell with just his voice and also the things that he had to say. I can't wait for you all to hear.
Yeah, we're going to learn a lot and we're going to relax in the process. So take a deep breath, but don't go anywhere. We'll be right back with Zach Swartz.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Zach Swartz, perioperative practice specialist at AORN. And Zach, thank you so much for joining us today.
Hey, thank you for having me.
All right, Zach, you are closing out Season 13, and not to put any pressure on you, of course, but I am incredibly excited about the topics that we're going to be covering today. And for those of you listening, it is topics. We have a 2-for-1 special. We're covering 2 different topics today, but I'm so excited I might spill the beans. So before I do that, Zach, why don't you go ahead and just tell everyone a little bit about yourself?
Oh, thank you. Well, the pressure is felt, but only slightly. But I am a nurse, a perioperative nurse. I've been a nurse for over 12 years, and the majority of that has been in the operating room. I do like to say I've done my time in endo.
So have I.
We all have. It's a rite of passage.
Yeah. I loved it, but yes. I've been fortunate enough to work in quite a few different settings, which means I've just moved around a lot. In some large academic centers, smaller community hospitals, and I've done pretty much everything that an OR nurse can do, from scrubbing, circulating, charge to assistant manager and an educator. So I've done a little bit of everything, and I've done a little bit of every service line, but I'm a neuro person at heart. Like, that is my bread and butter. You put me in a craniotomy and I'm happy.
I'm glad you're happy there. I will let you stay there.
Yeah, I was about to say somebody needs to be.
Put me in the total joint. You can have the craniotomy. We'll be good.
Perfect. We'll work together with that.
Exactly.
Love it. But outside of being a nurse and being in the operating room, I'm also a yoga teacher. I've been doing that for over 7 years now, and I've taught a little bit of everything. So I've taught from the one extreme of like a hot yoga class that makes you work really hard, and by the end of it you feel completely depleted, to restorative yoga where by the end of it you feel rejuvenated and relaxed and calm and quiet. So it's been a fantastic journey kind of figuring out both of those things separately, but also learning how to kind of blend them together and just see how one informs the other, and they completely do.
I am so excited to talk about that and hear how you have done that. And, really, when I found your profile on LinkedIn and first saw this OR nurse and yoga person, I'm like, hold up, how are we doing this? So I've wanted to talk to you for a while, and the LinkedIn messages between us can prove it, because I've tried to get you on the show a couple times before, and then my seasons didn't match up where I could say, yes, we can talk to him, but now we can. And so here we are. But before we dive into the yoga portion of our conversation, because I do want to hear how you have blended this. You also are an OR nurse, perioperative practice specialist now with AORN. And I'm curious, you are an author for the AORN Guidelines. How did you end up getting into that position, and what's it like to work on a guideline?
Yeah, it's, I'm not sure if I can really answer that first question all that well, to be honest.
It happened.
And I think LinkedIn linked both of us together, Melanie, but it also brought me to this position with AORN as a guideline author. And I saw the post on LinkedIn, was just like, I have to try. I've always wanted to work for AORN in some capacity. I feel like, perioperative nursing is my calling in life. I've always known that that's what I wanted to do since truly elementary school. It was like the dream job. So I figured I would just apply. And then if nothing else, I've put my name in front of them and just let them know who I am, and kind of maybe eventually down the road it would happen. And then it was just kind of like, well, first interview went well, we'll go on to the second interview, and then the third interview, and then the fourth interview, and then the writing prompt, and then the presentation. I'm just like, am I even capable? Like, can I do this? This is wild. But
right.
It's been a fantastic journey, and I know that I'm in the right place. I'm doing exactly what I should be doing. It's fantastic. So
it's really awesome.
And then the guideline process itself, I mean, the interview process was intimidating alone, but the guideline updating, that whole process is mind-blowing. So to explain that a little bit, so our guidelines get updated on a continual basis. So they get updated every 5 years, or hopefully it should be every 5 years. So you'll notice that, only a few guidelines every year get updated, and that's because they're on that 5-year cycle. And so to start that process, when a guideline is up for being revised or updated, we start the process with our medical librarian. And we lovingly call her our unicorn, because she is a perioperative nurse and a librarian, which, how many of those in the world exist?
I don't know, but I met her when I was at AORN headquarters a few months ago, and it was a pleasure to meet her. But yeah, I don't know any other OR nurse librarians out there.
So two passions that just came into one, I would imagine. Yeah, absolutely.
Exactly.
Kind of like yoga and nursing, right?
We've got two unicorns on the team, and I'm sure there's a few other. We have to figure out what their unicorn is. But yeah. So we start working with her, and we just kind of identify, what the topic is. So for me, this round is pneumatic tourniquets. And then we start to look at where's the direction that we want to go with this. So we identify search terms and what we need to see, what we need to find within that topic. And so she does the search. And then once those items are retrieved, we get hundreds, sometimes thousands of research articles over the last 5 years, hopefully, is kind of what we're looking for. So many, many research articles. And then so the author's first responsibility then is to just appraise. So you appraise every single piece of literature that is retrieved, and for quality, for the relevance to the topic, all of those things, just to make sure, because when you get hundreds and sometimes thousands of articles, not everything is going to be relevant, and not everything is going to be of quality that we should be using to write these recommendations and these guidelines. So that's our first step, is just making sure that what we're using, what we find, is useful and relevant. Then we really kind of deep dive into each of the articles. So once we've kind of appraised and whittled it down, so from maybe 400 articles that were retrieved down to like 200 that we think are relevant, somewhere around there, and it's different with every guideline, then we really read every single article. We make a lot of extensive notes. We appraise them for their quality. We grade them, and then kind of start to think big picture and say, what is this research telling me? What is this article that these researchers wrote? What is this telling me? What kind of conclusions can we make out of this? And then we start pulling all of those things together. And we kind of really essentially are translating hundreds of research articles and sometimes non-research articles like literature reviews or regulatory guidance from regulatory bodies like CMS, pull it all together, and then start to make recommendations from there. So when it's not a brand new guideline, like for pneumatic tourniquets, the guideline has been around for decades at this point. The framework is already there. And hopefully our goal by the time that we're finished doing this update is that the next time, 5 years from now, that when we do this update, there's probably not a whole lot of changing or updating that we need to do unless some really strong evidence comes up and just says, hey, maybe we need to do this differently, or maybe we need to have a different consideration when we're thinking about these topics. That's the bulk of the work, really, is just reading through those articles and then trying to make those conclusions, trying to figure out what does the research from the last 5 years tell us? What do we know based on the evidence is the right way to provide this patient care? And then from there, we live in our research bubble. Sometimes this is like a year-long process. So I'm in my research bubble, but I need to make sure that what I've written makes sense and that I haven't maybe missed or forgotten or didn't think about something. So we put the guideline draft up for public comment, and that's available on AORN's website for anybody to read through, make comments, make suggestions. If you know of a research article that I didn't happen to find in my literature research, and you want to put it in there and say, hey, did you think about this? Read this article. That's fantastic. That's probably the best public comment we could get is, you didn't think about this. This is where you get this information. What do you can you do something with it? That would be a dream for me. And then after public comment, the editor-in-chief and the guideline author will reconcile all those comments and kind of read through every single one. So everything that we get, we read and we accept it or reject it, or accept it with kind of a, maybe a little asterisk to it of like, that was a good comment. It brought us down this path. We'll figure out what we need to do with that. So after public comment, we take it over to our guidelines advisory board, which is a group of people who some of them are AORN members that have joined the board, and then some other representatives from other professional organizations. So organizations like the ASA or AANA or APIC, we have representatives. So, it's not just nurses who are looking at this, but our guidelines we expect that they are usable by the entire perioperative team to provide safe and competent care to the perioperative patient. So that we want to have that perspective from everybody. And then once the guideline advisory board votes to approve it, hopefully, then we publish, and that's it. Simple,
and then it's there for the next 5 years.
For the next 5 years.
No pressure.
So Zach, part of my job on this podcast is to bring a different perspective. And I am a certified surgical technologist. And I played a big role at our AST, the Association of Surgical Technologists. And one of the roles I play is also in our position statements on guidelines for patient safety. And interestingly enough, part of what we do in the national committee that I ran, and we take a lot of the same steps that you all do when we look at our position statements and the research behind it and updating it based on current patient safety and, the different, I think, outcomes that have come from studies and from the hundreds of thousands of publications that are out there. But when I did two things, by the way, to prepare for this interview. Number one is I went back and looked at AST's position statement on pneumatic tourniquet use. But number two was I did a yoga class. Thank you very much. And I'm not sure which one helped me better. So that will be decided. Hence thank you. And by the way, audience, thankful all of you should be that this is an audio podcast and not a video podcast. So apologies to Zach. But the question I have for you is I was very interested to see the position statement that AST wrote back in the day. And I think we're coming upon the time period for us to update that position statement as well. But out of the 102 different references that were cited, all the way from, AMA to good grief, so many articles and research studies that have been done. Do you know that AORN was only referenced one time? And AORN was only referenced in regards to antibiotic use and tourniquets. Anybody that would like to look at that, this can go down the Google stratosphere because it's, of course, available to the public. But I was curious because, surgical technologists have just as much to do with the proper use of pneumatic tourniquets within the OR as the nurse and the anesthesiologist does. And so I was curious as to if your committee looked at AST and our position statements and the things that, were posted there during all of your research, because, there is the Association of Anesthesiologists as well. And obviously there are several for surgeons, but there are all of these other foundations that put out their own, I guess, position statements about patient safety and how tourniquets and every other thing should be used appropriately. But do you all ever collaborate on these position statements and determine together what should be done, safely for the patient? Because we all have that same goal, right? Which is to treat our patient perfectly and to do the right thing so that we have, an excellent outcome.
Yeah, I think you bring up a really, really interesting, and I think this is really interesting. I will 100%.
It blew my mind. So I wonder, I saw the look on your face. It was like, really? 102 and y'all were only mentioned once?
Yeah.
That was shocking.
Well, and I think, I'm a self-professed nerd here. So I find the difference between wording extremely interesting and important. For AST, you said they are position statements. And for AORN, we have guidelines for perioperative practice. So so AORN does also have position statements. They're just like slightly separate things. And I think that it's always interesting when organizations start to reference each other. It sometimes can get a little bit cyclical, where like you reference me and then I reference you, and then everybody kind of goes into a circle if you're actually looking through the references.
Yeah, right. Yes, of course.
So I think maybe from my own perspective, just going through this process with this guideline right now, is I try to focus on the research that is conducted over the years, or the last 5 years, to see what the evidence is saying. And then if there is a place in the guideline where a small topic within the guideline where there's not research available, but I know that this is like an important point in the practice, sometimes we just have to point to other clinical practice guidelines and to other position statements and things like that, where the evidence is not available, but we know we need to make a statement about this because we know that something that the perioperative nurse and the perioperative team need guidance on. It's always frustrating when, as an OR nurse or as a surg tech, when you know that you have a question and you go to your place where you're supposed to get your guidance and it says, sorry, we can't give you a recommendation.
Right. Or it says one thing and then someone else's says another. And, and we collaborate in the OR all the time. And that's how you have an amazingly well-run OR. And, you'll hear throughout this season and seasons before and seasons to come, Melanie and I are screaming from the rooftops that we all need to work as a team,
Yeah, well, and if I can throw in real quick before we keep going, I think the one beautiful thing that you do see time and time again in your AST guidelines, along with your AORN guidelines, or maybe it's AST position statements and then AORN guidelines, whatever the correct terminology may be.
Lord knows.
I don't know all of them outside of, the OR nurse ones, but you'll see the guidelines, and what you really see that is so much more encouraging, instead of, like Zach was saying, just us referencing each other and going in a circle, is collaboration or corroboration of the research and of the things that are going to be best for patient care and patient safety. We're all saying the same thing most of the time. Everybody's got the same information. They're reading the research, putting out the information. And instead of just quoting each other, they're providing access to all sorts of information that then we can pull and say, look, everybody's saying the same thing. We need to be doing this. And then suddenly you have that whole arsenal of tools to say, this is the right thing to do. And so I think that is the very unique but great benefit to the different bodies who are all doing the research and putting out these guidelines is we have a whole bunch of people that are really saying the same thing most of the time. And we can look to each of them and say, yeah, see, everybody says we have to do this. And then we can go do that.
Right. And then hopefully everybody does that.
Yeah,
Which is
exactly.
great.
That's the hope, right?
Yeah. So what is the current guideline? Like, can you talk to that, Zach? Like, what is, just so that people maybe who aren't in the operating room
maybe just some bullet points.
Yeah, a couple bullet points. Like, what are the things that we do in the OR as far as pneumatic tourniquets that are going to keep our patients safe, as well as, hopefully a bloodless operative field, which is the goal.
Yeah, I'm so glad that you said that, Chris. Bloodless operative field is always the goal when you're using a pneumatic tourniquet. Number one, that's why we use them. We want that. There's a little asterisk to that. There are some other exceptions if you're doing like intravenous regional anesthesia or analgesia, like a beer block, something like that. But for the most part, when you're using pneumatic tourniquet, that's the goal, is you want a bloodless field so that the surgeon and the perioperative team can get in there, see the structures, the tissues, the things that they need to do, and blood's not getting in the way, and then get out of the way. Get out of there, right? Everybody wants to get through surgery as quickly as possible, as quickly and safely as possible. But so the guideline really kind of just starts with, and it's structured in a way that I think is just fantastic. I'm not biased in any way.
No, not at all.
That it follows the path of the perioperative patient and the flow of the perioperative team. So it starts with the preoperative assessment. First you have to just determine, are you going to use a pneumatic tourniquet or not? Is the surgeon or the anesthesia professional going to use one? There's your first question. And then it's a yes or no. And if it's a yes, then, the whole cascade kind of starts from there. So you assess your patient. And really the biggest things that you want to start assessing your patient for are the preoperative skin condition. Those pneumatic tourniquets are compressive. They put a lot of pressure on a small area of tissue on an operative limb. So you want to assess the skin, the circulation, because again, we're going to be stopping blood flow to an entire limb. So that's a big thing. So just know what their preoperative status is for circulation. And then also for sensory and motor responses, just making sure that, we have that preoperative baseline so that at the end of the procedure in the OR or in the recovery area, we know how that patient responded to the use of the tourniquet and whether they've had an adverse event. Either that's, they've kind of have a little bit of numbness, tingling, they've got pain, those kinds of things. We want to know what they were in the beginning and be able to kind of check their status afterwards and see how that's changed. And then the other really big considerations in the preoperative assessment are also any risks for complications or contraindications for pneumatic tourniquet use. There are some conditions and comorbidities that the research tells us just increase a patient's risk for having an issue or a complication after tourniquet use. And those include things like a low preoperative hemoglobin, because that greatly increases the need for a blood transfusion afterwards. Also, age. Being an older adult increases your risk because of the condition of your skin, the subcutaneous fat, all of those things that kind of just paying attention to the patient's anatomy. And also another really important one is an increased risk for blood clots, DVT or VTE, because again, we're stopping that blood flow, and that blood is static. It's just kind of sitting there. It's not, circulating through the body. There's a risk that a patient may develop a blood clot at that point. So if you are already starting off at an increased risk of a blood clot, using a tourniquet just greatly increases that. And then other contraindications, so like it may be an open fracture or an infection or malignancy of the limb, or if you already have a blood clot or DVT that you know of, those are things where we have to say, you know what, I know that I saw this in the patient's record, or they told me I have a blood clot in my limb. We need to take a pause. That's when you have a conversation with the surgeon and the anesthesia professional and say, hey, this is what I found in my preoperative assessment.
Sure.
Should we move forward with
I would imagine also things like whether it's a pediatric patient and also our morbidly obese population, like those two things matter as well when we're going to use tourniquets, Yeah.
Yes, exactly. And, one thing that I want to definitely emphasize, and something that I'm like really excited about for some reason, again, the nerd in
Hey,
me is
get
coming
it. We
out,
love nerds.
is that somebody has to, right?
It's because we are.
I'm married one. We're good.
Yeah. Especially with, with all perioperative care and considerations, but especially with pneumatic tourniquets, you want to individualize the care that you're providing to that patient with that tourniquet cuff at that location at that time. Everything is so specific. And like you mentioned, patient who has a higher BMI or the shape of their limb or some comorbidities that for another patient might not be an issue, but for this patient, because of all the things that they've got going on, that's when you need to kind of take a look and say, hey, is using a tourniquet the right thing to do? And do the benefits of using a tourniquet outweigh the risks or potential risks? So it's always so individual to the patient, and really to kind of bring home that what we were talking about before is it takes a really strong collaboration between the team to have that conversation. So it's not just the nurse, it's not just the surgeon, it's not just the anesthesia professional or the surgical technologist. We are all working in concert to make sure that what we're doing for that patient at that time with that tourniquet at that location is the right
And
thing
then
to
also, let your scrub tech know, because we need to get an esch mark, we need to get sterile web roll, we need to get all the things.
Yes,
before you ever wheel
exactly.
the patient back to.
Whole,
there's a chain.
That consequence of exactly.
So, okay, that brings us to, just for time's sake, the next part, right? Because all the stress of making sure that we have all of that and that we've cared for our patient and that we've done everything that we need to do, right? Brings us to the second part of our interview with you. And that is like, holy moly, after you've gone through this writing that you've done for this amazing guideline that we can all use for AORN, and you've done everything that you were doing as an incredible perioperative nurse to take care of your patient, you need the other part of you, which is the yoga instructor. And those of us who work in this high-paced environment definitely need your instruction. And as a horrible yoga person who takes the class and is awful at it, I will tell you my very favorite position, and that's Shavasana, and which is you lay there and you just breathe. And for those of you who don't know, right, you lay there in a supine position and you just take deep breaths and you listen to amazing voices like Zach's and you smell those incredible smells, and I fall asleep. And that's the only yoga pose that I know that I'm doing correctly. So other than that, I suck at every other pose known to man.
Well, I'll tell you right now, Chris, that there's no such thing as a bad yoga student.
Okay. And now you're my favorite person we've interviewed ever.
Exactly.
It's completely true. I think first and foremost, just getting onto the mat is hard enough, right? And just getting there. Just committing yourself to whatever the time is, whether it's 5 minutes, 60 minutes, 90 minutes, whatever it is, just getting there is like one of the hardest things to do. So once you get there and the intention is to move your body in a specific way, you're succeeding.
Okay, well, thank you. Because at 9 a.m. this morning, that was not it.
That's
But I did. At 9 a.m., my head was on you. I was like, I am doing this because I'm like, yes, because but no, it did not feel good. I was not breathing. I'm one of those people who holds my breath when I'm in pain. So breathing is always the hardest thing. I can get into warrior pose, but it's ugly.
Well, so we're talking about these different yoga poses, and you are already, obviously, your ability to be encouraging, Zach, is pouring out as Chris talks about her feelings of inadequacy. But let's go back a little bit to how in the world did you go from OR nurse to, I don't know if I should say yoga person, yoga instructor, yoga expert. So maybe you should tell me that too. But how'd you get there? What happened?
Yeah. So I'm so glad that you asked that question. I like, again, to me, words matter, and I'm like so particular about these things, but not in a critical way, but just something that I learned from my teacher. So I'm a yoga teacher. There's a difference between a yoga instructor and a yoga teacher. And the way that my teacher taught me this was, so an instructor will point to the moon and tell you it's the moon. But a teacher will show you the sky, show you the stars, show you the moon, tell you what they mean, tell you how you can find them, and then give you all the skills to be able to do that, find the moon on your own.
Oh my! I got goosebumps,
Wow.
Zach.
I like that difference. Chris,
I
you're
know.
a teacher.
Well, yeah, but obviously not in the yoga realm. So
None of the yoga world.
thank you, Zach. That was beautiful.
Yeah,
Oh,
Zach, I like that.
you have an amazing mentor.
So how did you end up in yoga?
Well, had been practicing for years, just kind of off and on. It was kind of a nice workout. I enjoyed it. It was fun to do. And then had just been working in the OR for several years and just kind of got to a point where I think maybe a few of us have felt this, where it's just, I'm tired. I'm unhappy. I'm burnt out. I don't like what I'm doing. And I didn't like that feeling of not liking what I was doing. Like I mentioned before, being in the OR is like my calling. I've always known that I wanted to be in the OR. So when I had that moment of like, I hate what I'm doing, I knew it was time to change that. So I really committed myself to a yoga practice and really kind of focused on, I need to do this for my own wellness and for my own sanity, essentially. And then then my obsession with just kind of blossomed, and I found a teacher that I connected with and vibed with, I guess. And kind of that was it. I quit my job. I moved 2 states away. I went through teacher training for 6 months, and then I came back to my home and started teaching from there. And it's been wonderful ever since.
But you also managed to blend. And I'm curious how you have blended your passion and love of OR nursing with your newfound passion in yoga. Like, how did you do that?
It's been interesting, just kind of going through teacher training and then starting to teach. You start to see where people, just where they are. Like that's one of the most important things for me, is just I like to meet a student where they are. So, like Chris, you said that you feel like you're not good at yoga.
No, I know.
Or you're Chris says she knows she's not good at yoga. So my joy as a teacher is kind of just recognizing where that student is and then kind of meeting them at that spot and saying, okay, so I can't ask the student to get into a really complex, maybe expert kind of level, if that even exists, yoga posture. But what we can do is we can drop the breadcrumbs. So we can start to teach, they get the student to start to recognize, like, this is what it feels like to move my body in towards this direction, or put my body into a position that gets there. I always like to teach kind of the basic classes where I start to just get people to notice the feeling of their hands and what your tendencies are when you're putting pressure on your hands. Say if you're in a down dog position where you're putting almost a lot of your weight on your hands. Do you even know what's happening with your pinky fingers?
Goes numb.
Like, are you putting the pressure? And so why does that happen, right? It's like my classes are always a conversation. Like, why does that happen? Let's talk about that. You feel like your pinky is going numb? Let's talk about that. Maybe you're putting too much pressure at the bottom of your wrist and you need to redistribute the pressure along all of your palm and all of your fingers and things like that. We do a lot of the same stuff in nursing, where we meet a patient out in the preoperative area and they start to tell us what's going on with them. Sometimes they tell us a little bit more than what we were asking for, but you start to just see kind of those little things, and then you start to notice the family dynamics or the dynamics with their support person or whatever. And they get nervous, so they laugh, or they get nervous and they shut down. And so you kind of start to just recognize, it's like those ad hoc assessments. In nursing and in yoga, you see a lot of that, where it's just you meet a person where they are and you get them to where you know that they can be.
That is amazing.
There's
the full circle of
just
incorporating everything. And as, of course, our time always comes up much faster than we're ready. But I don't want to end this interview yet until we get some advice from you, Zach, as OR nurses and surgical techs and anybody else listening. There are ways that we can incorporate yoga into our daily shifts into our time at work, and also some awareness that we can incorporate to maybe where we're holding tension or where we are just needing to be mindful, take a deep breath, those kinds of things. So what can you share with us today?
Yeah, I think that's like
it's a big mic to pass at you, but
no
still.
pressure.
well, here we go. Let's do it.
Yeah.
Do it. I think you said something that was just exactly right. Just bringing awareness to what's going on. A lot of So in yoga, there's a style of a yoga class called vinyasa, and the word vinyasa, some people associate with one breath, one movement, or a flow. You're moving from one thing to the next, and it's really flowy and beautiful and whatever. But the true meaning of the word vinyasa means to place in a special way. And so that could be your body physically, that could be your attention, that your awareness. So even just the act of placing your awareness on your breathing and the way that your heart is beating. We've all been in that position in the OR where we may not be working with our favorite surgeon or coworker or whatever, whoever it is, and they kind of just like make your heart rate go up a little bit high and your blood pressure kind of builds. You can hear your heart pounding in your ears sometimes, or somebody gets angry and yells or whatever. So instead of reacting to those things, just taking that moment to pause and recognize how you react, how you feel, what's happening within you, and then kind of regulating that reaction, that could be considered a yoga posture or a yoga moment. So just bringing your awareness to your breath, and nobody even has to know that you're doing it. All you have to do is breathe, which you do all day, every day anyway. And just doing it in a certain way that kind of helps bring your heart rate down and your blood pressure down. It's very simple and easy to do. Everyone can do that.
Okay, so because I have you as my captive interviewee, Zach, and I want to take advantage of your knowledge of breathing and yoga, can you teach us maybe a little bit of how to maybe guide our breathing or be aware of our breathing when we are in those situations?
Yes, let's do that. And I will start by saying, if you're listening and driving,
please stop.
Just make sure that that's your priority first. Drive first.
Pay attention
Don't
to the
stop
road.
breathing, but just pay attention to the road. But so let's just take a comfortable seat. So refresh your posture wherever you are. If you're sitting, just sit up nice and tall. It doesn't have to be anything big or fancy. Just refresh your posture. Bring your hands to the tops of your thighs. And then with the gentle downward pressure of your palms on your thighs, let that refresh your posture just a little bit. So nice and tall. Your right shoulder reaches out towards your right. Left shoulder reaches out towards your left. Nice and easy. So we're just going to inhale and exhale. We'll do both of those breaths for a count of 6, and I'll talk you through it. So just take an easy inhale in, and then an easy exhale out. And then we'll inhale. So inhale 2, 3, 4, 5, 6. Exhale 2, 3, 4, 5, 6. Inhale 2, 3, 4, 5, 6. Exhale 2, 3, 4, 5, 6. One more time. Inhale 2, 3, 4, 5, 6. Exhale 2, 3, 4, 5, 6. Just come back to your natural breathing. So taking those 30 seconds or whatever that was to intentionally breathe in a certain way, in for breath and out for breath, just pulls your mind into one thing, gives you a focus, and then naturally, as you slow the breath, your heart rate, your blood pressure will drop, the parasympathetic nervous system kicks in, and things start to slow down. And that's it.
That's awesome. My natural tendency is to close my eyes, and so then I'm like, oh shoot.
Yeah, we both had our eyes closed the entire time, I think.
But I had another person that we interviewed a few seasons ago talk about, breathing and being aware of your breathing and trying to incorporate that when it is stressful and when you are just it's chaotic, and is taking that moment to pause. Or if you're in the break room, in the locker room, and really decompressing, there is value in that, to be able to give the patient and your shift 100% of yourself. But you have to take time for yourself first in order to be able to give 100% of yourself. So thank you for teaching us just a little bit that we can take away and really incorporate. But before we go, do you have anything else you want to just leave the audience with?
I think the most important thing probably is, I think something, Chris, that you touched on very early in the beginning, is just that interdisciplinary, that whole perioperative team collaboration. And we are there to serve one purpose, and that is to get a patient through the perioperative process in a safe way that sees them as a whole person and that takes into consideration their wants and their needs. And so the whole guideline process for AORN and the whole process of, us working together in the OR is just to do that, just to ensure that we are all giving every single person that we come across that chance to have the best care and the best outcomes in one of the scariest times of their lives, probably. So thank you for bringing that up, and thank you for giving me the chance to be here and to talk with you.
We couldn't have said it better.
Oh, thank you. Yeah, definitely the perfect ending to a great season. So Zach, thank you so much for being with us today.
Thank you.
That was Zach Swartz, perioperative practice specialist at AORN. And Chris, Zach gave us a whole lot to think about, and there's a lot to unpack after our episode today.
There is, especially after I take a nap.
Yeah.
I'm so relaxed and more focused on mindfulness, but also it makes me want to be a better teacher. It makes me want to jump into the operating room, but also I'm so much more mindful of the process that goes into these guidelines. And it makes me thankful for everything that is done, especially in the realm of patient safety. I'm just grateful that he was a guest on our show, especially for the last episode of the season.
Yeah, I agree. I think it's helpful to hear the process and hear the work that goes into the guidelines, but then also to be encouraged by the similarities we see in the different organizations and the content that everyone is putting out that is all lining up to guide safe patient care. And so it's great to hear the process and hear how it works. But yeah, we did shoehorn two different unique topics into one episode, but I think that it's the perfect conclusion to season 13, because we are rolling into the holiday season with all of the hustle and the bustle and the sometimes utter chaos that it can bring at home and in the operating room. Definitely. And so I think it's helpful to have those tools in our toolbox to help us relax, to focus, to have some mindfulness, to release that tension that we always seem to be carrying. Plus, we also got some great reminders about tourniquet safety and some things that we need to be aware of. And it's always helpful to have that in the back of our brains as well. So everyone listening, be on the lookout for the guideline update that will be coming out soon, and check out that guideline just to make sure that you are up to date on everything that is in there for tourniquet safety. And if I can throw one more thing out as well, if you enjoyed our interview with Zach, he does have a book out. His book is entitled Be Still, a 6-week at-home restorative yoga guide. And Zach designed this book so that you could do restorative yoga at home with what you have at home. No extra weird tools necessary that you got to order. So keep that in mind. Go check it out if you're interested. But that is going to do it for this week's show and for this season. We'll be back soon with season 14. But for now, on behalf of Chris, myself, and our entire team, thanks for listening to First Case.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.